For millions of women living in Malawi's rural districts, healthcare is not a short walk or a phone call away. It is a journey, sometimes kilometers long, across red dust roads and open fields to reach a service that may or may not be there when they arrive. In rural Malawi, the gap between a woman and the healthcare she needs is not measured in minutes. It is measured in money she does not have, in roads she cannot safely walk, and in clinics that were never built close enough to matter.
Kuchokera kuno kwathu kwa Nkulumimbo ukafika kuchipatala kwa Chiluli mtunda umwe ufuna mayendedwe. Panova kuti upite ndi kubwera zimatitengera ndalama zokwanira 14,000 kwacha. Ndengati ndalama ulibe nde kuti thandizo lonse lavuta kuti ulipeze.
Akazi anga akamapita kuchipatala chakuchitedze amayendaso nthena kamavutikira chifukwa ndi vuto tumwawo na chifuwa chasima. Ndiye chifukwa choteteza kwa zimenezozo ndimaonetsetsa kuti nthawi zonse ndiwapatse ndalama komwenso kupeza ndalama panopa ndikovuta kwambiri. Zimakhazi zotipweteka.
Penaso mapeza zonotapita kuchitedze kuja thandizo sakalipeza.
Access to family planning is not a luxury. It is the foundation of safe motherhood. Without it, pregnancies happen before families are ready. Women's economic lives stop. Children arrive into conditions that were not chosen.
Family planning is a pillar on safe motherhood. If we are not doing well in family planning, definitely the indicators on a safe motherhood part, they also fall.
Azimayi amene ali pansinkhu wa ubereki modera langa lino ndekuti ndi 450. Kotero kusapezeka kwa njira zakulera ndi chiopsezo chachikulu kuti mabanja akhoza kusowekera thanzi lawo komanso zitukuko zikhoza kukhala zovuta. Koteronso ndeti olo ana akhoza kukhala onyenchera wochuluka.
And behind these numbers are the lives they represent. A woman who cannot plan her family, cannot plan her business, cannot plan her child's schooling, cannot plan her own health. The consequences of a broken system compound quietly, invisibly, until someone measures them. For years, one answer had been found. The Family Planning Association of Malawi, FPAM, had spent decades bringing services directly to the women who could not reach them. Through mobile outreach clinics that traveled deep into these communities, they brought something essential: choice.
So our team does a comprehensive mixed package whereby we offer family planning services. In family planning services, we have both groups, short term and long terms. And also we provide the STI services, at the same time HTS, whereby our clients are tested for HIV and AIDS, and also cervical cancer screening. We also do immunization for under 5 children.
Momentum Tukweze Umoyo project was one of the biggest partner in the district. They were taking almost 35 outreach clinics running concurrently across the district, giving the services of family planning and antenatals.
We've seen that there's an increase in uptake of family planning that justifies that we should continue giving these services. And this has helped to prevent unintended pregnancies.
In early 2025, a decision made far from Malawi sent shockwaves through the country's health system. USAID funding was abruptly discontinued. The mobile clinics stopped coming. The tents were packed away. The nurses who had become familiar faces in these communities were gone.
Abrupt discontinuing of momentum, it was a big blow to the district. It was a shock to us because we were unable to reach to the areas that we were to reach without the outreach clinics.
Sinimembekeza kuti mkazi wanga kozopezeka kuti ali ndi pathupi chifukwa ngati banja mmayenera kukambirana nthawi yoyenera kuti mayi ayembekezere kapena kuti ngati banja mukhale ndi mwana wina. Ndeno chifukwa cha zovuta zina malingana ndi kusowa kwa mankhwala odzitetezera mwachidule kulela na amene wapangitsa kuti mkazi wa ine upezeka kuti ndiwoyembekezera pamene tisanakambirane. Kubwera kwa mwana ameneyo amene sanabwere mnyengo yake wasokonezabe zinthu zina, nkhaniso amagwiridwa ntchito ngati chitukukoso pa khomo chayima.
They were causing congestion in the health facilities, which meant giving workload to the staff.
And then, in the code language of official records, the toll became impossible to ignore.
We lost almost 2 mothers in the period of March to April, maternal death.
The International Planned Parenthood Federation had seen the gap forming. With emergency funding mobilized through their harm mitigation grant, they reached out to their partner on the ground, FPAM, with a simple mandate: get back into the communities fast.
Us as an organization, we are aware of the challenges that people face when it comes to access to sexual, reproductive and health services in Malawi, and that's why we do exist as an organization. Following the departure of USAID funding, there was a huge gap that was left, and us as an organization came in very quickly to continue with the provision of services.
Harm mitigation team has managed to provide services to 21,445 clients.
In one outreach clinic, we reach out 250 people, and these people, they receive family planning, STI screening, VIA, as well as HIV testing and counseling. So the most preferred package is family planning.
Family planning, as these communities understand it, is not simply a health decision. It is an economic one, a social one. When a woman can plan her family, her husband can plan his work, her children can plan their future.
Njira zolerera ni zabwino chifukwa zimatithandiza kuti ana athu akule mwathanzi komanso chisamaliro chizipezeka.
Chipatala chimenechi choyendachi chatithandiza kwambiri chifukwa chonena kuti amatichepetsera ntchito ngati ife alangizi za umoyo, chifukwa ngati anzathu asanabwere timapezeka kuti ife ndi amene tikuwapatsa anthu njira zotani zolera. Komanso ife pali zipangizo zina zomwe sitimapezeka nazo, komanso pali zina zomwe kuti ife sanatipange train ndi sitimakwanitsa kuwafikira anthu. Komanso amatithandizira kunena kuti azimayi kapena atsikana asatenge mimba zosayembekezereka.
Nditamva kuti FPAM akubwera, ndapanga ndi amuna anga chisankho ichi kuti tidzatenge njira imene yakulera, kuti tithandizikirenso kuchepetsa chiwerengero kapena kutenga mimba zosayembekezereka. Chifukwa atakhala ndi mwana pompano, kutsogolo kuno tidzathenso kukhala ndi mwana wina kumano uyo atakula.
Mayi pamene akutenga njira yakulera amapezeka kuti iyenso akukuthandizira ntchito zina zimene ngati bambo umatha kupeza nazo mathandizo apakhomo kuti mukwanise kudya tsiku ndi tsiku. So ngati thandizo limene litati kuti likumaduka mosayembekezeka, amapezeka kuti tikupeza nazo mavuto ochuluka ngati kumoyo yathu wa tsiku ndi tsiku. Choncho ifeyo ngati banja komanso ngati bambo ineyo ndikanakondetsetsa kuti thandizo limeneli lisayimire pompa, lisaduke mwa njira ina iliyonse, chifukwa limatithandizira mu moyo wathu wa tsiku ndi tsiku.
The impact of the intervention was measurable. Family planning utilization rates, which had fallen sharply during the crisis, began to climb once more. But the district health officers were careful to celebrate with one eye still open.
When things were okay, the utilization rate was at 68%. So when we were distracted, it dropped to 61, and it dropped further to 55. But now it peaked, it's at 61. So we'd like it to go back to 68%. That's why I'm saying FPAM can increase their numbers as well. We are satisfied, but not really. They can do more.
Coming of FPAM with this project was a welcoming matter, and indeed we are very happy with this project because it is the only project that is running across the district, meaning they had to reach areas with the services of family planning. It means the coming back of FPAM with this project, it was a relief for the program. By then, we are reaching about 46,000 in a quarter, 41,000 in a quarter. But I can tell you, last quarter, we have reached out 51,000 women getting the services of family planning, putting our utilization rate at 88%. Now, FPAM alone, this project, it contributes almost 3,800 in a month. So you can see in a quarter, it's almost 11 to 12,000. It means that figure that we are having of 51,000, it means almost 12,000 is from this project.
Trust was being rebuilt through results, through women who returned home healthier, through children who were wanted, planned for, and cared for. The numbers told a story of recovery, but recovery is not the same as security. The first phase of the harm mitigation project came to an end on the 31st of March 2026. On the 1st of April, round 2 began. But the question that hangs over all of it is the same question that has always hung over healthcare in rural Malawi. For how long? And on whose commitment?
As a country, we have made strides in terms of reducing the maternal mortality. It is reported that we are at 225 compared to 381. About 68% of all women are on contraceptives. Over the past 10 years, our total fertility rate was around 4.4 children per woman, but now we are at 3.7. Teenage pregnancies have been on the increase. In 2015-2016, it was reported that teen pregnancies were at 29%. But in 2024, Malawi Demographic Health Service, it was reported that it is at 32%, which is an increase instead of going down. So this is one of the areas really that requires considerable investment. And at this point, I think I would like to ask the government to critically look into this, because investment in health is going to have an impact on other sectors of the society and also sectors of the economy. And therefore, we really need to work together to ensure that we continue to provide high quality and accessible SRHR services as a country.
The case is not only moral, it is mathematical. Every dollar invested in family planning reduces the cost of maternal health complications, keeps girls in school, and grows household incomes. The return on investment is real, measurable, and compounding. The clinics are still coming. For now, they are still coming.